Okay, so this is Dr. Jeffrey Olin. I'm here asking him a series of questions on Buerger's disease. So Dr. Olin, as one of the most distinguished experts on Buerger's disease, we wanted to get your opinion on whether you think there's any proper treatment or therapy that exists for patients with severe Buerger disease at this time, for which vascular bypass is not adequate.
Okay, well, let me start by saying that bypass or endovascular therapy with stenting is rarely an option in Buerger's disease because it occurs in the distal blood vessels and there's really not a target for bypass. So the only therapy that's been definitely proven to be effective is discontinuation of tobacco in any form. Even those patients who chew tobacco can get Buerger's disease. Also, cannabis or marijuana can produce a syndrome called cannabis arteritis, which is very much like Buerger's disease. So the most effective therapy is discontinuing tobacco or marijuana completely. And if that happens, the patients virtually never end up with an amputation. Other therapies really have not been shown to be terribly effective. There is a large study from France a number of years ago using the prostaglandin analog, showing that you can get quicker healing of ulcerations in Buerger's disease at 6 months and decrease pain. But no therapy has shown that you can completely heal the ulcerations due to medication alone. So that's a long answer to a question, but really the only therapy that's ever proven effective is prostaglandins. It has to be given intravenously. The patient needs to be monitored in the hospital when they give it because the blood pressure can drop. And really discontinuing smoking is the most effective way to prevent problems in Buerger's disease.
Great. So that leads on to question number 2, which is very similar. So there is a list of medications here, including silostazol, and that are approved in Korea currently and used for the treatment of Buerger's disease. But can you provide your thoughts on some of these medications?
Yeah. Sure. Let me first start with argatroban. Argatroban is a direct thrombin inhibitor. It's given intravenously. And it's an anticoagulant. There's no role for this in Buerger's disease. Anticoagulants do not help in any way. And if you were going to use argatroban, there would be no reason to use it because there's now an oral direct thrombin inhibitor, dabigatran, that's available. But I would not use that. That's not effective. Silostazol has never been shown to be effective in Buerger's disease. All of the randomized trials have been in patients with atherosclerotic peripheral artery disease, showing that it can improve claudication. But there are no studies showing that it helps with the relief of rest pain or the healing of ulcerations. The other thing with silostazol is that it's very poorly tolerated, and about 60% of the people who start silostazol are not taking it by the end of 1 year because they've had side effects related to it. You have a number of prostaglandins listed here: Limiprost, Bariprost, Alprostadil. None of them are effective given orally. There was a study looking at one of them with oral administration, and it was not effective. But Iloprost, or PGI2, has been effective when given intravenously. The other medications we don't use in the United States, and I really don't know anything about, so I won't comment on them.
Okay, great. So my next question is the difference of Buerger's disease in comparison to peripheral arterial occlusive disease. Can you explain the difference on the pathological aspects of these two diseases and why they do not use the same medications?
Okay. First, nomenclature. In the United States, we don't use the term peripheral artery occlusive disease. We use the term peripheral artery disease, or PAD. that's atherosclerosis. That's the same thing that happens in the coronary arteries of the heart and the carotid arteries. So this is related to all of the cardiovascular risk factors: high cholesterol, high blood pressure, diabetes, smoking. And this produces obstructions of the arteries anywhere in the arterial system and can affect the aorta and the iliac arteries. So this is really atherosclerosis. This is the most common cause of circulatory problems in the United States and Western Europe. Buerger's disease, or thromboangiitis obliterans, is an inflammatory vascular disease. So something in tobacco produces an acute inflammatory response, and it's the only disease that causes a very highly inflammatory thrombus. This disease affects the arteries below the knee and in the foot, and the arteries below the elbow and in the fingers. So peripheral artery disease does not affect the arms or the hands, but Buerger's disease does, not infrequently. So Buerger's disease is an inflammatory vascular disease. It's not related to cholesterol or diabetes. It is related to smoking, and it affects the small blood vessels of the upper and the lower extremities, and it affects the veins. It can produce a superficial thrombophlebitis, etc. Peripheral artery disease is typical atherosclerosis, the same thing that happens to people who have heart attacks or strokes.
Okay, perfect. My final question to you is regarding some of the symptom relievers that are being used right now, including xylostazol, variprost, and limiprost. So can you explain the potential side effects with these drugs?
Okay, xylostazol has been very, very well studied in the United States, and there are a number of papers looking at long-term retention of people started on xylostazol, and it's very poor. The three most common side effects are headache, palpitations, and diarrhea. And as I alluded to earlier, only about 40% of people who are put on xylostazol are still taking it at 1 year. They stop it on their own because it makes them feel so poor. The other thing about xylostazol is there's a contraindication to its use in people who have had heart failure or an ejection fraction less than 40%. The prostaglandins, the major side effect is hypotension, and that's why with intravenous infusions they need to be monitored very, very closely. So with a 6-hour infusion, they need to have their blood pressure checked frequently. They can also get headaches, stuffy nose, and things like that, but nothing serious.
Okay. Did you want to comment on other therapy that should be used instead?
Well, there's really no good therapy. We start everyone on aspirin as an antiplatelet agent, and generally do not use the medications that you have listed here. What we do use, if we're not participating in a clinical trial, is if someone has ulcerations in their fingertips or in their toes, we use an arterial pump system. And this was first described at the Mayo Clinic, where you put a 2-bladder cuff on, let's say, the calf, and it inflates to a pressure of about 100 millimeters of mercury every 8 seconds. And it kind of forces blood into the limb. So that has been shown to help heal ulcerations if the patient's also able to stop smoking. But it takes a long time. They have to do it for 6 hours a day, and it takes many, many months before the ulcer will ultimately heal. But that's more effective than any medication that's available to date.
Okay, sounds good. Thank you very much for your time.